As mentioned, the topic I'm going to cover today is the treatment of psychomotor agitation. It's a very broad syndrome. So the definition of agitation is a bit different across the ocean. It's a condition in which patients display excessive verbal and or motor activity. But again, in the definition, it doesn't say and motor activity. It could be only excessive verbal. It could be only unquiet. What is the etiology of agitation? One of the most common and important causes of agitation are organic mental disorders. For those who work in nursing homes for the elderly, they know that many patients with dementia get agitated. The cause is alcohol withdrawal. Then we can also solve this with some medication. So clearly, there are situations, fever, etc., where identifying the etiology is critical to treat the situation. But in most cases, we are going to give symptomatic treatment on top of the etiological treatment. So for non-organic mental disorders, even though these disorders have a biological background, we have two groups: the psychotic disorders, including schizophrenia and mood disorders in general, mostly bipolar and mania. This is the most common causes of agitation, apart from drugs. Schizophrenia and bipolar, we can have some clues. The age of the patient, maybe the history of epilepsy or other reasons of alcohol abuse, etc., can help us. What is extremely important when defining agitation is to understand this S-curve, this profile in which patients start with some tension. This is time, and this is the severity. Agitation starts very mild, and then suddenly it escalates and gets to a very high severity dysfunctional. So one of the critical points for agitation is early intervention. So the intensity of agitation can go from mild to severe. The patient can be cooperative when the severity is mild or moderate, and when the agitation is very severe, the patient is normally less cooperative. Until recently, the only options we had were oral and intramuscular. So for most patients, we would use oral intramuscular, and oral would be for milder patients and cooperative because they have to ingest the pill, and for less cooperative and more severe, we would use the intramuscular. This is the group of experts that we joined on agitation, and we searched for publications on the topic, and we identified a number of experts across the world. These is organized by the World Federation of Societies of Biological Psychiatry, prepared a systematic review of the topic, and then did a Delphi study to provide clinicians with a number of recommendations for agitation. And this is now in press. It's going to be published in the World Journal of Biological Psychiatry next year. But these are the recommendations that came out from the systematic review and the Delphi consensus. So the first one is that agitation with no provisional diagnosis or with no available information should be presumed to be from a general medical condition until proven otherwise. Second point is the routine medical examination in an agitated patient should include a complete set of vital signs, blood pressure, glucose, oxygen, and toxicology. Third recommendation is, after treating agitation, systematic assessment of sedation level should be performed. For agitation, we don't want more effective treatments, because if it's too effective, it's oversedating. So efficacy is not the critical point. The critical point is the fast onset of action. The fourth recommendation of this panel was that the initial approach to a patient with agitation should always start with verbal de-escalation. This means environmental modifications and other strategies that focus on the engagement of the patient and not on physical restraint. The fifth recommendation was that verbal de-escalation should be always used in cases of mild to moderate agitation. The sixth recommendation from the panel was that physical restraints should only be used as a last resort strategy. So again, this is the same message in different ways, when it is the only means available to prevent imminent harm. The seventh point is that in front of risk of violence, the safety of the patient, staff, and other patients should be preserved. When they are necessary, there are restraints and seclusion. These two options are sometimes necessary, but then you need proper monitoring and the use of quality indicators. In the case of physical restraint, vigilant documented monitoring should be mandatory, and vital signs should be measured every 15 to 60 minutes. Physical restraint should be removed as soon as the patient is assessed not to be dangerous anymore for him, herself, or others. This is also a very important statement. Non-invasive treatment should be preferred over invasive treatments whenever possible. The 12th recommendation is that agitated patients should be as much as possible involved in both the selection of type and the type and route of administration of any medication. The main goal of pharmacological treatment should be to rapidly calm the agitated patient without over-sedation. When planning involuntary pharmacological treatment, team consent should be reached and the action carefully prepared. Oral medications, including solutions and dissolving tablets, should be preferred to intramuscular route in mildly agitated patients. So a rapid onset of the effect and reliability of delivery are two most important factors to consider the choosing the route of administration. And again, this is an issue, for instance, with benzodiazepines. But benzodiazepines, if they're given intramuscular, they have a very erratic absorption. You have patients who have a very rapid onset of action and patients who take very long. And you never can guess whether the patient is going to have an overreaction, oversedation, or nothing. So it's very difficult to predict the response to benzodiazepines. In alcohol withdrawal, we shouldn't use antipsychotics. We should use benzodiazepines. But in other situations, for instance, alcohol intoxication, it is better to use an antipsychotic than a benzodiazepine. In mild to moderate agitation and when rapid effects of medication are needed, inhaled formulations of antipsychotics may be considered. We should avoid the combination of intramuscular olanzapine and benzodiazepines because there are reports of oversedation with this combination. Intravenous treatment should be avoided in the majority, 99% of the cases, avoid intravenous treatment. And elderly patients need lower doses. So these are the statements, 22 statements from the most renowned experts in the world on this topic. Now let me talk about a new treatment. What we are starting to use, and now there is 2 years of experience in Germany and in Spain, so that's why I'm going to speak about it. We have 2 years of experience with this product. This is loxapine. In Spain we had it oral, and it's also available in France as an oral antipsychotic. Let me show you here the profile of the drug, pharmacodynamic profile, and particularly this fact that even though it is historically considered a first-generation antipsychotic, in fact it behaves as a second generation because the affinity for the 5-HT2A is higher. You know that the lower the number, the higher the affinity than the affinity for the D2. So this behaves, loxapine behaves as an atypical antipsychotic, even though it's classified as the first generation. Now, why is loxapine novel if it's so old that has 35 years? Well, it's novel because some guys in America invented a way. The device has a heating surface when they put the dust of the drug, and then it vaporizes immediately, and it gets into the lung. So what is the advantage of using this route? The advantage is that this route doesn't go to the liver like oral medications, and it doesn't need to be injected like injectable medications. So it's clearly a way to get a similar effect as intravenous without the risks of having intravenous medication. We give 2 doses per day on the top. Normally we give 1. This is the device. I don't know if you've seen the original one, is this size, more or less. And it has this surface where the drug is like a dust, a very fine base of dust of the drug. And then there is here, you take this tap, which activates a heater, electronic heater, and then this heats and vaporizes. So once you activate the device, if you put the device in the mouth, in milliseconds, you get the drug. Now, what this does is that this vapor goes into the lungs, and the lungs have, as you know, the capillars. And the capillaries get oxygen and all the gases that go into the lung. So it's like capturing the drug in very little time. This is the pharmacokinetic profile, and you can see here this is minutes, and this is how long it takes to take the maximum level in the blood. Tmax is 2 minutes. Between 1 and 2 minutes, you get the maximum levels. And I'll show you the trials that show that you can get a response in very little minutes. In 10 minutes, there is a separation from placebo. And these are the results of the 2 main studies. One study schizophrenia, another on mania, bipolar. Here you can see that the first time that the difference were assessed was 10 minutes, and in 10 minutes there was already a highly significant difference between 5 or 10 versus placebo. And of course, this was significant until the 2 hours endpoint, which was the primary endpoint of the studies, and even at 24 hours, it was still significant. But I want to remark that there was no single case of over-sedation. So this is very important because the patients get calm, but they don't get to sleep immediately. The main side effects, because of the way we use is dysgeusia. Dysgeusia is bad taste. As you can see, it's quite safe and quite tolerable. These are the number of patients with no adverse event. Some of them complained about somnolence, sedation, but not over-sedation. This is the bronchospasm report, and I want to mention it because one of the concerns with this medication was if the patient has asthma or congestionary obstructive pulmonary disease, it's very exceptional to have a problem related to that. It's true that for safety measures, the European agency requested that this device is given in a hospital setting. As you can see in the trials, there was only one patient with bronchospasm and another with cough as a side effect. And in all cases, they resolved well. So a few instructions on how to use it if you want to try it. You first open the pouch, and then you get the device. Then you take out the tag, and you have 15 minutes to use it. Otherwise, then when you do this, there is a green light that you can start using it, and it lasts for 15 minutes. After 15 minutes, you haven't used it, you have to discard it. The ideal way to use it is that to make the patient exhale, and then you put this in the mouth, and when the patient gets some air, then you get the effect. It goes immediately into the mouth. You don't need to do anything exceptional, just to put it in the mouth and breathe. And agitation, when the patient presents to treatment, you have to do these minimal things that were recommended by the experts: do a history of vital signs, a medical assessment, and if the patient is starting to be nervous, verbal de-escalation is very important. To speak quietly, to tell the patient everything's going to be all right, let me help you, etc. If you see some increased agitation, potential for violence, verbal de-escalation, and oral medication could be one choice. If the patient is already too aggressive, too violent, too agitated, uncooperative, you might need to use restraints and intramuscular. But what you really want is to intervene in a point when the patient can still cooperate. And this is what you need: rapid intervention, because oral medications are too slow. And many patients, you give an oral and they get agitated in 10 minutes or 20 minutes, and the oral medication hasn't started to work. And the intramuscular is too invasive, and the restraints are too invasive, and the patients don't love us if we do that. They won't become our friends if we do that. They won't see us as good doctors, even though sometimes it's necessary. So in conclusion, I think agitation is a syndrome that can happen in the context of many conditions, can rapidly escalate. Early intervention is crucial. The use of restraint should be avoided whenever possible. The management requires verbal de-escalation, plus in most cases medication, and mostly benzodiazepines or antipsychotics. Orals are slow but non-invasive. Intramuscular are faster but invasive. And the inhaled formulation, I particularly like it because it's fast and non-invasive. This new treatment that we've been using in Spain for now 2 years has shown that it works. We are quite happy with it. From the hospital budget, it's not very expensive because it's only one treatment per patient normally. So it's not something that you give for a long period of time. It's only contraindicated in patients with asthma and congestive obstructive pulmonary disease who are decompensated, or of course if they're allergic to loxapine or amoxicillin. Grazie, thank you very much.